This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
We do have the prompt program in our institution, but this actually complements the prompt program. And I'd like to just acknowledge Dr. Steve Scroggs, who's the Clinical Director of Obstetrics and Gynaecology at Flinders Medical Centre where I work. I'm going to give you a bit of background to the hospital where I work. I'm going to give you some obstetrics MET data and general obstetrics data, some MET data in general, so you've got a bit of an idea about what kind of work we do. And then a bit about the rationale for collaboration and why MET and obstetrics came together. We're going to talk about the workshop, the logistics and the key learnings and the evaluation. So this is where I work, Flinders Medical Centre. It's one of two major trauma centres located in the southern suburbs in Adelaide, South Australia. We have just under 600 beds. We're co-located with Flinders University and Flinders Private Hospital. We have on average 5,500 admissions per month with about 70,000 per annum. We have a 32-bed general ICU and that ICU has about 2,200 admissions per annum. And our intensive care unit is a general ICU, so we have adults, paediatrics, obstetrics, surgical, neurosurgery, you name it, we have it. So the types of patient groups that come to Flinders Medical Centre, I've already said we're a major trauma centre. We have adults, paediatrics. We are the South Australian Northern Territory liver transplant unit and obstetric state referral centre, and we're a level 6. So we're the only site in South Australia that has obstetric trauma. In terms of the services at Flinders Medical Centre, in terms of obstetrics, on average we have about 3,500 obstetric separations per annum. We have a total of 43 obstetric beds at Flinders Medical Centre over 3 separate locations within the area, within the hospital, with 10 gynae beds. On average, this slide shows you the ICU obstetric admissions. We're sitting currently at about 47 obstetric admissions to the ICU per annum. MET service where I work. So we have on average, we're now sitting at about 2,200 MET calls, which is almost the same amount, a number of ICU admissions. So about just under 200 calls a month, 6 a day. Our average response time to a MET call, no matter where it is about 2.5 minutes. We spent on average about 30 minutes at a MET call, and the average age of the patients that we attend to for the general MET calls is 66 years of age. And this is just that, looking at it visually, since 2004 when we implemented the MET service at Flinders Medical Centre. Now, there was one of the main changes that happened to us at Flinders Medical Centre was the implementation of the track and trigger chart, and this is the maternal observation chart that we implemented as part of also the adult and 5 paediatric charts in 2013 where I work. And as a result of that, you can see where the star is that we had a significant increase in obstetric MET calls, which is okay, that's all good. But you can see that from 2013 there has been a steady increase in both obstetric and gynae MET calls. And if we break that down a little bit more, we're sitting on an average about 36 calls per annum for obstetric calls. Previously we were about 9 calls per year, obstetric calls with 3 a month, 1 a day, and then down below, once a week, sorry, and then down below you can see I've divided up the gynae cohort as well. What are the reasons for obstetric MET criteria activation? So what we're currently seeing where we work, and we do have modified maternal criteria, so systolic BP of less than 80 is sitting for just under 50% of the reasons for activation, of the reasons why we're attending calls. With significant bleeding right down the very end, actually, it's probably only sitting at about 3%. The outcomes for the obstetric MET calls, over 80%, as you would imagine, do remain on the ward. But 13% of those do end up being transferred to a higher level of care, either the operating theatre or the transfer to ICU. And we've had no deaths on the ward for the obstetric patients. Now, with all this information that I've just presented to you, that was sort of the impetus for us to start thinking about how we could collaborate with the MET and obstetric services. So on the outside, you can see I've delivered to you the increased activity, which then made us think about, well, there are competing demands between all the different disciplines when they're coming together, obstetrics, anaesthetics, ICU. The perceptions for each discipline, the expectations that they have of themselves, and the MET doctors thinking that perhaps I need to know how to deliver a baby, when in actual fact that wasn't their role. And we had some significant feedback pre-implementation of this workshop and collaboration, particularly from obstetric doctors, about communication breakdown and conflict and disrespectful behaviour on the MET team's behalf. And I think that was all as a result of communication breakdown, lack of role clarity. None of us knew really what we were doing and what our role was when we came together for a maternal emergency. Confusion and teamwork disconnect. So all of those kind of things have made us think about, well, and we do know that, and this is what we wanted to prevent, was sentinel events, because we do know communication failure is 70% cause for sentinel events, and we didn't want to be there. That we decided to put MET and obstetrics together as a team. Now, this is one sort of team, not quite sure that that's actually the team we wanted to achieve. It's a little bit slow. My children weren't very impressed with me that I had such a slow one on. So that's not the teamwork that we want to show, but this is the kind of teamwork that we wanted to end with, where you can see a very collaborative approach where everyone's working together, and we've got the obstetric and the MET team working together here. So we developed what we call Obstetric TeamMET. I think in the synopsis in your actual program it talks about MET and foremost, which actually is what it was called to start with, but we've recently turned it into what's called Obstetric TeamMET, which is a collaboration focused on teamwork and communication, which I think I heard small bits of team and communication in the previous presentations, but to me it wasn't a strong theme necessarily, so that's why we've decided to use this platform to complement the prompt. All of the midwives in our institution have to do the prompt program. It's mandatory, and all the obstetricians and gynae doctors. It's not mandatory for the MET team, but this particular course is a mandatory course for the MET team providers. The key outcomes of the Obstetric TeamMET program are to have improved management of obstetric emergencies, improved multidisciplinary team and communication, increased ability to prioritise tasks when you come together to treat a woman, improved use of ISRRS, and reduced time delays, errors and adverse outcomes. So we developed a one-day workshop, and on average we have 20 participants, and the day sounds very similar to the prompt program, but we actually don't use any of the actual core content from the prompt program because you can't, because it's owned by prompt, which is fine by us. We're smart clinicians, and we've developed a program. So lectures, skill stations, clinical simulations and debrief. Obstetric team members attend, midwives, training, O&G docs, anaesthetists, MET team members, both nursing and medical team members have to attend, and we have the day incorporates an actor and a mannequin, the use of a mannequin, so you can see that. There's pre-reading online, and there are lectures. So some of the lectures are about communication teamwork, which is pivotal to the day. Also, I present a lot of stuff on statistics, so it's very relevant to their local area where they're working, so they get an understanding of the types of obstetric MET calls that they're having. We have a lecture on advanced life support and perimortem C-section. Not that I think we actually haven't had one yet, thankfully, but there is that risk that might happen one day. Also, postpartum hemorrhage. We have a lecture on postpartum hemorrhage, something very specific, and also preeclampsia, because that's really important for the MET team providers to have an understanding about preeclampsia. There's also several skill stations. One of them is on airway support and cricoid pressure, arterial line management, intraosseous use, postpartum fundus and inverted uterus, and use of the massive transfusion pack. Some of these skill stations only the MET team go to, and some of them only the midwives attend and obstetric docs, and some of them everyone comes together. So the massive transfusion and the postpartum fundus and inverted uterus is applicable to everyone and is of interest to everyone, but the care of an arterial line or airway support and cricoid pressure isn't something that the MET team providers attend. In this, they actually have the intraosseous and I can't remember the other one of the other skill stations. So we sort of split it up depending on the interests. And these next two slides just show the interaction at a skill station of the midwife showing the combined teams, and there as well. The simulations. So we have 6 simulations throughout the day. 5 of them are with an actor, that is a paid actor, that's her role. She does a lot of work with the medical students, and 1 is with a mannequin. So there's 1 on respiratory collapse, there's a cardiac arrest where they actually have to do a perimortem C-section, and that one is a new one that we've put in that actually occurs in the ICU unit, which is very different. So it's about what are the resources and what are the challenges when the obstetric team come into my environment as opposed to us going out to their environment. We have 1 on severe preeclampsia, eclampsia, oliguria, postpartum hemorrhage via normal vaginal birth and concealed postpartum hemorrhage. I'm going to just take you for the next few slides. I want to show you visually how the day runs to get a bit of an idea. So this particular slide has the observers and then has the midwife, and she's just received handover and assessment, and half the team are observing while some of the other participants are waiting to come in when they're called. But what happens here is Mary's received her handover and she's talking to her patient and doing an assessment. She's done her A to E assessment and she's had to activate the internal emergency bell. Then the team that was in her immediate vicinity attend, and they're now activating a 33 hash because of what they've found. They've done an A to E assessment and they've also got their obstetric emergency trolley. This is the obstetric registrar and this is the intern. Then the MET team arrive, and you can see that there's a lot of people around, and you can see here's the MET doctor and there's the obstetric doctor. This is my favourite slide, and this wasn't staged, this was actually during a simulation, but you can see the anaesthetist has gone to the head of the bed. You've got the obstetric reg and the MET doctor collaborating and talking together jointly about the patient. In the background you can see the MET nurse with the midwives preparing some medications. You can see the facilitators in the background, and then you can see the scribe and one of the junior doctors also getting some equipment out. So this is what we are aiming for, is communication and collaboration. Here's another example of teamwork, communication and priority of tasks between the midwives and the MET nurse. And most importantly, the debrief is so important that we do after every simulation. So that's where we talk about the experiences, understandings, and we can reflect on our practice. The key principles for simulations that we always talk about when we go into these sessions: it's safe, it's not an assessment, everyone's to work within their professional boundaries, we need them to reflect, share experiences, we don't talk about things outside the workshop, and it's a trusting environment to enable immersion. There's been some significant key learnings that we as MET providers have been able to, and facilitators have been able to take back into our own practice just from facilitating these workshops that we just weren't aware of before. One of them is about the medication. So we carry mag sulfate and hydralazine in the MET bags, but we don't normally, we use it for whatever we use it for, but not traditionally in obstetric patients. And so when we've been immersed in these simulations, we've been exposed to, they actually drew up mag sulfate differently and hydralazine. So it's been a whole new learning curve for the MET team and a greater understanding and appreciation. We've now added a scalpel blade to the MET bags for the awful event that we have to do a perimortem C-section and deliver in the first 2 minutes. Obstetric emergency trolley has been one piece of equipment that the MET team's been exposed to, because they're very, they've been dedicated only to the obstetric areas, and previously we were never aware of them and what was in them. We now have stubby laryngoscope handles in all of our airway kits, which are very relevant for the obstetric population, and we've been made aware that they actually have a specific airway kit in the birthing assessment suite. Some of the key clinical learnings that we've taken away and that we've been able to be involved in from this collaboration is we now have an anaesthetist attend all obstetric MET calls. Prior to that we didn't. We don't have an anaesthetist attend our MET service at all because our doctors can intubate. But we've realised that in this population, airways change significantly and they're very difficult intubations. The other role for the anaesthetist is to facilitate transfer to the operating theatres very quickly, and also they're an additional resource. Increased collaboration between the MET team and obstetrics, and also as a spin-off, because we've had more patients coming to the ICU and we're having to have more collaboration with the obstetric service, there's been a better collaboration within the ICU between obstetric clinicians and ICU clinicians. To date, there's been 16 workshops with 227 participants, and it started in 2012. That just shows the disciplines that have come. I'm just going to go through this very quickly. All the feedback has been extremely positive. In summary, we've been able to see some significant practice improvements just from facilitating and being involved in these workshops as facilitators. So there's been a spin-off for us as well as for the people participating in terms of clinical practice improvements and communication. Simulation is an effective education forum. We're very proud of this because it's very multidisciplinary, it's collaborative, and we've had very positive engagement. And we've got consultants come to these workshops, anaesthetist consultants, so it's a great thing to see. So thank you.